So these are the key players in the direct oral anticoagulant sort of
all of those are
pile-up.
named after Star Wars planets. I just
That's right.
That's where Yoda lives.
That's where the inspiration came.
The Gabatran system, I'm pretty sure.
So dabigatran is the oldest, and so that's Pradaxa, and that was FDA approved in 2010. That's the only direct thrombin inhibitor, and I'm going to show you the coagulation cascade shortly, and that will make you lightheaded and diaphoretic. Don't worry.
I can't wait.
And then the other ones are factor Xa inhibitors, and the way you can sort of remember those is that they all have that XA in them, rivaroxaban, apixaban, edoxaban, which is the newest one, and so that XA is that factor Xa inhibitor,
like
so
that.
kind of a little
Never noticed that.
shortcut there, yeah. Here we go! All right, I'm only going to point out two things with this. Be not afraid, my friend. Be not afraid. So the direct thrombin inhibitor that we talked about, dabigatran, it works right here. All right, so here's thrombin. So it's going to inhibit thrombin, which then, if that's not working, you can't get fibrinogen converted to fibrin, and so there's no clot formation.
Okay.
So that's how that anticoagulant effect happens. With the factor Xa inhibitors, here's factor Xa, which is responsible for the conversion of prothrombin to thrombin. And so then you sort of have this indirect thrombin inhibition with the factor Xa inhibitors.
It's all coming
and
together.
so everything is just basically to prevent thrombin from doing its thing there.
Okay.
See, that wasn't so painful.
No, it's all right.
No, I kept it
I'll
simple.
accept that.
All right, good. All right, excellent. So that's what your arm looks like, right, Aaron?
That's exactly what my arm looks like.
So-
right before I shoot, you have to do heroin
sensed it
if your
through
arm
your
looks like
tight shirt.
You must do intravenous drugs.
So what do we love about these direct oral anticoagulants? So they're rapid onset. We don't have to bridge patients with like heparin and Coumadin. There isn't this like initial procoagulant effect that then becomes an anticoagulant effect. So as soon as it's on, it's on. They also have short half-lives, so upwards 10, 12 hours and they're gone. So that's lovely if we need to sort of stop treatment for surgery or some sort of a procedure. It's a fixed dosing schedule, which is nice as well, because warfarin, one day it's like 5 milligrams and then 10 and 7.5, and it shifts all over the place. No dietary restrictions, so eat all the dark, leafy, green vegetables you like. You will not mess with these.
I was going for donuts, so yeah, leafy green is better.
And you don't have to monitor the anticoagulation. So the patients don't have to keep coming in to get their INR checked over and over and over again. So that's
or you can't
lovely.
monitor it.
You can't monitor it.
It's not that you don't have to, it's that we can't.
Yeah, I guess that's what I should say, yeah. So what's the bad about this? So 2 of the medications have BID dosing instead of daily dosing, so that's kind of a drag. Dabigatran and apixaban have BID dosing. These are renally cleared, so patients who have any sort of like chronic renal insufficiency or acute kidney injury, then you could sort of end up screwing around with the dosage, so you have to sort of take down the dose to account for the GFR. Mm-hmm. We don't have a lot of experience with these drugs, unfortunately.
Yeah.
So, initiating them from the emergency department can get tricky, or then sort of managing the complications of these drugs can be tricky. And then the reversal is difficult. So we're comfortable with Coumadin, right? I know how to reverse warfarin quickly. With this, I don't necessarily know what I need to do. What am I supposed to do if someone comes in and they have this intracranial hemorrhage? How do I make this stop? How do I make the bleeding stop?
Hard enough to pronounce them.
Without having to pronounce them, yes.